Rethinking Obesity, Moving Beyond BMI to Address Metabolic Health. Introduction. Obesity is often misunderstood as merely an issue of excess body weight, but emerging research highlights that it is a complex metabolic disorder affecting organ function, inflammation, and energy regulation. Traditional diagnostic methods such as body mass index, BMI, fall short in capturing the full picture of metabolic health, leading to underdiagnosis or misdiagnosis of individuals with normal BMI who may still experience severe metabolic dysfunction. A growing consensus among researchers emphasizes the need to redefine obesity by incorporating clinical and preclinical stages. This approach helps identify individuals with early signs of metabolic dysfunction, even in the absence of overt weight gain, allowing for targeted interventions to prevent long-term health consequences. Understanding the nuances of obesity and employing more accurate diagnostic methods can pave the way for personalized treatment strategies that restore metabolic balance and improve overall health. The limitations of BMI, why it's an incomplete measure. BMI has long been the standard for diagnosing obesity by calculating a ratio of weight to height. However, BMI fails to differentiate between muscle and fat mass, leading to misleading classifications. Individuals with high muscle mass may be categorized as overweight or obese despite having optimal metabolic health, while others with normal BMI may harbor visceral fat that compromises organ function and increases disease risk. Key limitations of BMI ignores. Body composition. BMI does not distinguish between lean muscle and fat, overlooking individuals with high muscle mass. Fails to detect visceral fat. Visceral fat, which surrounds organs, is more harmful than subcutaneous fat, but remains undetected by BMI. Misses metabolic dysfunction. Individuals with a normal BMI may still experience insulin resistance, fatty liver, and inflammation, contributing to metabolic syndrome. Scientific insights on BMI's limitations. A study in the Lancet Diabetes and Endocrinology highlighted that 20% of individuals with normal BMI exhibited significant metabolic dysfunction, underscoring the need for more precise diagnostic tools. Research in JAMA Internal Medicine found that up to 50% of individuals with obesity-related metabolic dysfunction were missed when relying solely on BMI. Preclinical and clinical obesity, a new framework for diagnosis. To address these limitations, experts propose distinguishing between preclinical and clinical obesity to identify early metabolic dysfunction before it progresses to organ damage. First, preclinical obesity. Preclinical obesity refers to a state where fat accumulation is beginning to impair metabolic function but has not yet resulted in significant organ damage or clinical symptoms. Individuals with preclinical obesity may have increased visceral fat, hidden fat deposits around organs that disrupt normal metabolic processes, elevated inflammatory markers, low-grade inflammation that contributes to insulin resistance and chronic disease, subtle metabolic changes, early signs of impaired glucose tolerance and dyslipidemia. Second, clinical obesity. Clinical obesity, on the other hand, occurs when fat accumulation actively harms organs, impairs daily function, and contributes to chronic disease. Signs of clinical obesity include fatty liver disease, excess fat accumulation in the liver leading to inflammation and fibrosis. Cardiometabolic dysfunction, elevated blood sugar, blood pressure, and cholesterol levels, reduced mitochondrial efficiency, impaired cellular energy production, and increased oxidative stress. Scientific insights on redefining obesity. A study in Obesity Reviews suggested that reclassifying obesity based on metabolic dysfunction rather than BMI alone could improve early intervention outcomes. Research in the Journal of Clinical Investigation proposed that visceral fat measurement, inflammatory markers, and insulin sensitivity assessments should be incorporated into routine obesity diagnostics. Visceral fat and its role in metabolic dysfunction. Visceral fat is metabolically active fat stored deep within the abdomen, surrounding organs such as the liver, pancreas, and intestines. Unlike subcutaneous fat, which lies just beneath the skin, visceral fat releases inflammatory cytokines that disrupt insulin sensitivity, promote oxidative stress, and increase the risk of chronic diseases. How visceral fat contributes to metabolic dysfunction. Increased inflammation. Visceral fat secretes pro-inflammatory cytokines like TNF-alpha and IL-6, which drive chronic inflammation and insulin resistance. Impaired insulin sensitivity. Excess visceral fat interferes with glucose uptake, leading to hyperinsulinemia and type 2 diabetes. Altered lipid metabolism. Visceral fat increases triglyceride production, contributing to dyslipidemia and cardiovascular risk. Scientific evidence on visceral fat and metabolic risk. A study in diabetes care demonstrated that visceral fat accumulation was a stronger predictor of insulin resistance and cardiovascular risk than body mass index. Research in the American Journal of Clinical Nutrition found that reducing visceral fat through diet and exercise improved metabolic markers, even without significant changes in BMI. Effective strategies to address preclinical and clinical obesity. Addressing obesity requires a comprehensive approach that targets metabolic dysfunction, inflammation, and mitochondrial efficiency. Adopting strategies that eliminate harmful dietary components, enhance insulin sensitivity, and correct micronutrient deficiencies can restore metabolic balance and reduce the risk of chronic diseases. 1. Eliminate vegetable oils and reduce linoleic acid, LA, intake. Vegetable oils, high in omega-6 fatty acids, linoleic acid, contribute to mitochondrial dysfunction and oxidative stress. Excessive LA intake promotes inflammation and impairs fat metabolism, exacerbating metabolic dysfunction. Tips to reduce LA intake. Avoid processed foods, fried items, and seed oils such as soybean, canola, and corn oil. Opt for healthier cooking oils like coconut oil, olive oil, and grass-fed butter. Increase omega-3 intake through fatty fish or high-quality supplements to balance the omega-6 to omega-3 ratio. 2. Improve insulin sensitivity through strategic carb use. Restoring insulin sensitivity is critical for reversing metabolic dysfunction. Contrary to popular belief, strategic carbohydrate consumption can improve glucose metabolism and enhance mitochondrial efficiency. Tips to enhance insulin sensitivity. Choose whole food carbohydrates like sweet potatoes, fruits, and legumes, which provide fiber and nutrients. Pair carbohydrates with healthy fats and proteins to slow glucose absorption. Practice carb cycling or periodic refeeding to prevent long-term carb restriction and maintain metabolic flexibility. 3. Correct micronutrient deficiencies. Micronutrient deficiencies can impair mitochondrial function and exacerbate metabolic dysfunction. Key nutrients like magnesium, zinc, vitamin D, and B vitamins play essential roles in energy production and metabolic regulation. Tips to optimize micronutrient status. Incorporate nutrient-dense foods such as leafy greens, grass-fed meats, and nuts into your diet. Supplement with bioavailable forms of magnesium, zinc, and vitamin D to address deficiencies. Monitor nutrient levels through regular testing to ensure optimal intake. 4th, incorporate strength training and walking to enhance mitochondrial efficiency. Physical activity, particularly strength training and walking, enhances mitochondrial function, reduces inflammation, and shifts the body's energy balance toward muscle instead of fat storage. Benefits of strength training and walking. Increased muscle mass, improves insulin sensitivity and enhances glucose utilization. Enhanced mitochondrial biogenesis stimulates the production of new mitochondria, boosting cellular energy. Reduction in visceral fat promotes fat oxidation and reduces inflammatory markers. Scientific evidence supporting physical activity for metabolic health. A study in Diabetologia demonstrated that strength training reduced visceral fat and improved insulin sensitivity in overweight individuals. Research in the Journal of Applied Physiology found that walking 30 minutes daily improved mitochondrial function and reduced inflammation in adults with metabolic syndrome. 5. Improve mitochondrial function through lifestyle modifications. Mitochondrial dysfunction is at the root of many chronic diseases, including obesity. Enhancing mitochondrial efficiency through nutrient-dense foods, adequate sleep, stress management, and intermittent hypoxia techniques can restore metabolic balance. Tips for mitochondrial support: prioritize sleep and circadian rhythm alignment to support mitochondrial repair. Manage stress through meditation, yoga, or breathing exercises to reduce cortisol-induced mitochondrial damage. Incorporate intermittent hypoxia or breath hold techniques to stimulate mitochondrial biogenesis. Conclusion: obesity is far more than excess weight. It is a multifaceted metabolic condition that affects organ function, inflammation, and mitochondrial efficiency. Relying solely on BMI as a diagnostic tool overlooks metabolic dysfunction in individuals with normal weight and misclassifies those with higher muscle mass. By adopting a new framework that distinguishes between preclinical and clinical obesity, healthcare professionals can identify early signs of metabolic dysfunction and implement targeted interventions to restore health. Strategies that include reducing linoleic acid intake, improving insulin sensitivity, correcting micronutrient deficiencies, and incorporating physical activity help reverse metabolic dysfunction and reduce the burden of obesity-related diseases.